Okay, so this is going to bring us to talking about fascicular blocks. And to have a discussion about fascicular blocks, we need to understand what bundle branch blocks are, and we need to understand how to determine the axis, because axis determination is a big part of identifying fascicular blocks. So let's talk a little bit about how the bundle branches are configured. So I have a little drawing here. Let me put this up on the screen for you guys. You see that? Perfect. So I have a little drawing here of the conductive pathways to the lower part of the heart. So right up here is the AV node. You guys good with that? All right, so as that impulse gets delayed at the AV node, right, that allows for the ventricles to fill, right, and there's your P to R interval, and then it passes through. It goes through the right bundle branch, and then down through the left bundle branch, and then those bundle branches carry that wave of depolarization out into the His-Purkinje fibers and into the ventricular tissues. So if you look at the right bundle branch is pretty much a straight pathway, and it doesn't have any major proximal bifurcations to it. You guys okay with that? Bifurcations. Bifurcates branches until you get down, a lot lower where it branches out into the His-Purkinje fibers. However, the left bundle branch, very early on, upon leaving the bundle of His out of the junction, bifurcates into two major what we call fascicles. You have the left anterior fascicle. So this is the part of the left bundle branch that wraps around into the anterior part of the heart. And then you have a part that wraps around the posterior part, the left posterior fascicle. So the left bundle branch is divided into the anterior fascicle and the posterior fascicle. The right bundle branch doesn't have any major fascicles. It's kind of just one main pathway.
Atomically, is it more closely aligned to the posterior or the anterior portion of the heart?
Posterior. Yeah. Yeah, so it kind of wraps around the back of the ventricle. The anterior wraps kind of comes up front. So you could imagine the anterior popping out of the board at you.
But I mean, I was just asking about the right. Is it more closely aligned following the left?
The right. It goes to the right side,
okay.
right? The right ventricle primarily.
Okay. But I mean, it doesn't. I guess it doesn't wrap around to the back, or it doesn't wrap around.
No, pretty much just goes out. Yeah, it goes out into the right ventricle, and yeah, so it doesn't have that major wrapping. Okay. And again, because you have so much more tissue in the left ventricle, that's why you have this bifurcation, these different fascicles. So you could imagine that I could have damage to one or more areas of these pathways, and that would block conduction through those areas of the heart. And so that sets us up for mainly 4 different types of special blocks that can occur. Okay, I can have a block of the left anterior fascicle, and if I just block the left anterior fascicle only, and the left posterior and the right bundle branch are okay, that would just give us something known as a left anterior hemiblock, or a left anterior fascicular hemiblock. Is everybody okay with how we could get that? Okay. Likewise, I could have a block of the left posterior fascicle, although that tends to be very rare. This is not something that we commonly see, the posterior fascicle. And if we just had a block of the left posterior fascicle, that would give rise to a left posterior fascicular hemiblock, or a left posterior hemiblock. You guys okay with that? That kind of makes sense? Okay. Now, I could also have a blockage of, and maybe I'll select a slightly different color here. I could block one of the fascicles, particularly the left. I could have a blockage of the left anterior fascicle, okay? And I could have a right bundle branch block. which would just leave the left posterior fascicle open for conduction down into the ventricles. You guys okay with that? When I have this situation where the left anterior fascicle, so the left anterior fascicle gets blocked, and the right bundle branch gets blocked, we call that a bifascicular. A bifascicular block. Are you guys okay with the terminology there? It does not mean a blockage of both the left anterior and the left posterior fascicle. Because if I blocked both the left anterior and the left posterior, what kind of block would I have? A left bundle branch, right? So a bifascicular is a right bundle branch plus a fascicular block, plus a fascicular hemiblock. Does that make sense? Okay. And then finally, we can also get something called a trifascicular block. And again, this is kind of tricky. The terminology is tricky here because if I blocked everything, the right bundle branch, the left anterior, left posterior, what would that give me?
Ventricular rhythm.
Yeah, it'd give me nothing, right? It'd give me some ventricular escape rhythm, right? So what we mean by a trifascicular block is a bifascicular block, with an AV block of any type. Okay? That's what they consider the other quote-unquote fascicle, even though it's not. So if I have, select a different color, we'll go green here. If I have a block or a delay of conduction up here, and a right bundle branch, and a left anterior fascicular hemiblock, okay, that is what we call a trifascicular. A trifascicular block. You guys okay with that? So let's just rehash this real quickly again. A left anterior fascicular hemiblock is just an isolated block of the left anterior fascicle. You guys okay with that? A left posterior hemiblock is a block of the left posterior fascicle. You guys okay with that? Okay. A bifascicular block is a right bundle branch block plus a left anterior fascicular hemiblock. And then a trifascicular block is a bifascicular block plus an AV block of any kind. It could be a first degree, could be a secondary type 1 or type 2, or it could be a complete heart block. You guys okay with that? Does that make sense? Sort of? Kind of? Okay, cool. So what I did is I just kind of made up a an algorithm, if you will, that you can follow. So let's go to fascicular blocks. How do we identify fascicular blocks? So we start at the top. The first question you ask is left axis deviation present? Hence the reason that we need to be able to identify axis deviation, okay? And what I mean by left axis deviation is pathological left, all right? Generally, these cause like negative 40 and up, okay? So, you know, well within pathological. So pathological, is pathological left axis deviation present? If the answer to that question is yes, then you ask, is there an RS complex? Okay, this is an RS, a little r and a big S. A little r and a big S. You guys okay with that? Is a little r, big S complex present in the inferior leads? If the answer to that is yes, your patient has a left anterior fascicular hemiblock. So left anterior fascicular hemiblock, okay, presents with left axis deviation and a little r, big S complex, and leads 2, 3, and AVF. You guys cool with that? Make sense? All right. Now, we,
RS complex.
little r, big S.
That's just what it means. RS complex means little r, big S.
Yeah, little r wave, big S wave. Yeah, and it kind of was that, and I'll show you some examples here in just a few minutes. Now, that's not the end of the story. If we have a left anterior fascicular hemiblock, then you need to ask yourself, is a right bundle branch block present? If the answer to that is yes, guess what? You have a bifascicular, right? So a bifascicular block is all of this stuff here plus a right bundle branch block. And that all equals a bifascicular block. Are you guys okay with that? Okay. And then finally you ask yourself, is an AV block present? And if the answer to that is yes, you have a trifascicular block. All right. So all of this, whoops, there we go. All of this plus an AV block gives us a tri. So you can have a left anterior fascicular hemiblock, a bifascicular block, and a trifascicular block. Does that kind of make sense there? It's kind of crazy, isn't it? Is everybody okay though? You guys see how that works? Okay. Are you guys writing this down?
Yes.
Okay, write this down, and I want you to pull your notes up from yesterday when we talked about axis deviation, because we're going to reference that here in just a few minutes. Okay. So let's go back up to the top now, and let's say that left axis deviation isn't present. So there's no left axis deviation. So if you do not have left axis deviation, you cannot have a left anterior fascicular hemiblock. So then you go down the no pathway and you ask, well, is there right axis deviation? If the answer to that is yes, then you go, well, is there little r, big S morphology in the high lateral leads? Those are leads 1 and AVL. If the answer to that is yes, that is a left posterior fascicular hemiblock. So a left posticular fascicular hemiblock is right axis deviation and a little r, big S in your high lateral wall leads. That's lead 1 in augmented vector left. Okay? Are you guys okay with that? Okay. The next thing that we need to be aware of is if we have axis deviation, before we go down this pathway, we need to rule out the common causes. So, what are the common causes of LAD, left axis deviation? This is where I want you guys to reference your notes from yesterday.
Right bundle branch block could cause left.
Could.
Obesity?
Say again?
Obesity?
Okay, obesity.
Misplaced heart?
Okay, so heart position.
Left bundle branch block?
What's that?
Left bundle branch block?
Good. Left bundle branch block. Okay.
Left ventricular hypertrophy?
LVH. Yeah, that's a big one.
Ascites?
Ascites. Good. Good. All right. So if you have a left axis deviation, and you can attribute that to any of these causes, that would stop you from going down the fascicular block pathway. Okay, so when you have axis deviation, you got to ask yourself, okay, can I account for that with any of the major causes? Nope, I don't see any major cause. Okay, now I'm going to enter the fascicular block pathway. Does that kind of make sense? And the same thing goes with right axis deviation and the left posticular fascicular hemiblock. And there are fewer causes of right axis deviation, but let's just review them. What are some causes of right axis deviation?
Right bundle branch block, right ventricular pulmonary diseases.
Good, so RVH, right, chronic lung disease,
um,
specifically the core pulmonale, I believe.
Yeah.
All right, okay. So if you have those that can account for that, then you have you be very careful about going down that pathway. You guys okay with that? Make sense? Did you write the pathway down?
Yes.
Okay, let's go through some examples then. Okay, so what's the first question we ask? Okay, so is LAD present? How do we find the axis here? Yeah, we look at leads 1, 2, and 3. What do we have? I've got up. You guys see that okay? Down, down. That gives us pathological LAD. Check. It is, yes. So we move down, and then what do we ask?
There's RS complex.
In
Inferior leads.
inferior leads. There we go. So,
Yes.
look at that. Right? Is that a little R wave? Sure is, right? It's not a Q wave. Q waves go down, right? It's the first downward. You don't have a Q wave, so you got a tiny little R here. And then what do you have? Big old S. Okay, so the little r, big S in inferior. What do you think?
Yes.
Yes. So what are we looking at here?
Left anterior fascicular hemiblock.
Do we stop though?
No.
No. We go down, we ask. What's the next question we ask?
No.
No, it's not.
Right bundle branch block, no, and we stop there, right? That's the end of it, and so we stop at a left anterior fascicular hemiblock. How crazy is that? A couple weeks ago, you guys probably would have looked at this and gone, that's a normal sinus rhythm. Right?
What if they're like obese, anything else?
Yeah, so if,
We can
yeah.
attribute that.
Yeah, if you can strongly attribute that. But in this case, because you have LAD and because you have the R, little big S, you know, there's definitely more evidence pointing toward a fascicular hemiblock there. You guys go with that? Okay, well let's try it again here. All right, so is LAD present?
No.
What do we have?
RA.
So what's a lead 1 here? Up, down? What is it? So it's more down, right? Okay, and then lead 2 is up. Lead 3 is up. What does that give us?
RA. Right up.
No. So that whole left-hand pathway is done for. So then we go to the right. Is RAD present? Absolutely. Okay, and then where do we go from there?
RS morphology, or,
Little r, big S in
ABL and
the high lateral leads. Good. RS in 1
ABL.
and AVL. So let's look at 1 here. There you go. You got your little r and your bigger S there. Let's move down to AVL.
Small.
Little r, big S. You guys agree? Bam. So what does that give us?
Left posterior hemiblock.
Good.
But,
Fascicular.
is there, the hard block has nothing to do with, I mean, you don't look at any blocks?
No, not with,
No.
yeah. Because there's no bundle branch, yeah.
No, I meant, like, AV block.
Yeah, that's, not gonna. Yep. And if an AV block was present, it would not change the diagnosis of a left posterior.
Only with the,
Only with an
anterior.
anterior, yeah.
Try.
And then you're looking at bi and tri, and, yeah. You guys cool with that? How crazy is that? I don't know, I get a kick out of being able to identify these kinds of things. Okay, moving right along. Let's look at this guy here. And again, I've got links referencing where I got these from. All right, so let's start on the left. Is there patho
Yes.
LAD? Yes. Why?
Down, down.
I've got up in lead 1, down, down, so yes. Then where do we go?
The RS.
Right, so is there little r, big S in 2, 3, AVF?
AVF for sure.
AVF, but 2 doesn't.
Yeah, definitely there. AVF, yes. Yeah, look at that. You got the little upward, see that there?
But in 2, it doesn't look like it's quite, would that still be considered? Because it looks pretty even both sides.
Well, where's the S wave?
I'm sorry?
Where's the S wave?
Going up.
Down.
Oh, yeah.
No, S wave. S wave is right here, right?
No,
No,
in
no,
2.
on 2.
Oh, I'm sorry, in 2. Alright, so where's the R wave?
Going up.
Going up,
And then the S?
down, well.
The little r, big S?
Oh, you don't go from the center? Like, I was looking at the.
So there's a
from
R?
the center to the top and then the center to the bottom. You would go from the.
Yeah. Is the R wave smaller than the S wave? That basically is what you,
Okay,
yeah.
Yes. I was
Yeah.
thinking like each side, like
Yeah.
the top half of
Yeah.
the.
Does that make sense though?
Yes.
Okay, cool. So yeah, so we've got it. Maybe a little more subtle there, but I think we'd all agree, yeah, I think we're, get rid of those marks there. So we'll say yes. Is that it though? So at this point, what do we know we have?
Left anterior.
Fascicular hemiblock.
Left anterior fascicular hemiblock. Okay. We got to keep asking more questions. What's the next question we ask?
Bundle branch.
Is there a right bundle branch?
Yes.
Yeah, let's move over to V1 here. Is it, first of all, is it QRS wide?
Yeah.
Oh yeah, sure is. So let's turn signal that bad boy. Where's the arrow go? Up. What does that give us? Yeah, it gives us a right bundle branch block. And so what does that give us? A bifascicular block. And I don't know if there's a rhythm strip on this one. There isn't. So you'll just kind of have to take my word for it that there is no AV block. Which, yeah, there isn't. So we would stop there with bifascicular block. You guys good with that? All right, cool. Let's see here. Let's take a look at this one here. So let's start again. Is patho left axis deviation present? Yes. What's lead 1? It's up. Lead 2? Down. Lead 3? Down. So, yes. And then what?
QR or RX.
2, 3, AVF. All right, so little bigger, little bigger, little bigger. Okay. So you guys okay with that, more or less? Yeah. So what does that give us at this point?
Left anterior.
Fascicular
Why can't I hear that?
That's okay. That's all right. Okay, so we know that the left anterior fascicle is blocked. Let's keep asking questions. What's the next question we ask?
Is there a right bundle branch?
Is there a right bundle branch?
Yes.
Sure. Let's wrap. Yeah, you got your little RSR prime there. It's wide. Let's turn signal that bad boy. It goes up. Yeah, so that definitely gives us a right bundle branch. So what does that put us at?
By this.
Yeah, so a bi. So that means that both the right bundle branch and one of the fascicles in the left is blocked. Would you guys go with that? Anything else going on though? Let's go to our let's go down here to our rhythm strip. What do you notice?
Junctional.
There's a P wave.
The P isn't the down after that?
Yeah, so it's right here. It's the first. It's a biphasic P wave, but it's a P wave there.
Okay, I thought the P wave was the.
Yeah, it's kind of a half and half, right? So it starts here and then ends there. It's what we call biphasic P wave.
Okay,
But what can you guess?
but it's by.
The P to R interval.
From the.
First degree.
Yeah, first degree AV block. Would you guys all agree? What does that give us? That gives us a trifascicular. Any sort of AV block will give us a tri. You guys good with that? Some people will say that this is an incomplete trifascicular block because it's not a third degree heart block. But at this point, as long as you guys just call it trifascicular, I'm fine. Incomplete versus complete doesn't matter. It's still trifascicular. You guys okay with that? So why do we care about this? This seems like some pedantic, nuanced stuff to really focus in on. Why do we care? Well, when we're assessing our patient and we're doing serial 12 leads on our patients, if your patient starts off with just a hemiblock, so let's say that the patient starts off with a left anterior fascicular hemiblock. That's not a huge concern, right? They still have a lot of alternative pathways for conduction. And then let's say 5 or 10 minutes later, you run another 12 lead. So maybe this patient's having a STEMI on top of all the other things, right? So maybe they're having a STEMI, right? Oh, you identified STEMI. Good. Pat yourself on the back. You got it. You also identified that there is a left anterior fascicular hemiblock. Wow, you're smoking hot at interpreting these things. So 5 to 10 minutes later, you've gone from that to a bifascicular. What should that tell you?
It's progressing, possibly going to the tribes.
Yeah, that's telling you that this patient's conductive system is dying, is dying in front of your very eyes. Why is that a problem? What would you anticipate if you see this happening? And then let's say 10 minutes later you do another 12 lead, and now you notice a trifascicular.
It could result in ventricular rhythms.
Yeah, what kind of dysrhythmias would you be most worried about? No. What's going on here?
It's done.
But what's going on with the conductive system?
You're not gonna have a sinus rhythm anymore.
Okay. And so what kind of rhythm are you probably?
Escape.
Some sort of escape rhythm, right?
It's gonna be slow bradycardic.
There you go. That's the major thing, the major take-home point with all this fascicular block business is as you see this developing. Okay, so let's say you start off with a left anterior fascicular hemiblock. If you see this patient deteriorate into a bifascicular block, what would you want to do for your patient? Well, not necessarily, right? Because as long as the rate's okay, right? But you would want to
Prepare to?
there you go. The fascicular blocks are all about preparation. This is telling you that their conductive system is dying. And so if you saw this, you would want to put pads on them, right? You'd want to have those pacer pads on and ready to go. Now, do we put pacer pads on every patient having chest pain? No. But would you be justified in blowing $100 putting pacer pads on this patient?
Yes.
And then, I don't know about you guys, but do you get called in if you do things that waste a lot of money? You ever get called on that? No? No? You guys are lucky. There's some places like, why did you do this? Right? Why did you, the patient wasn't in cardiac arrest. You didn't pace the patient. You didn't cardiovert the patient. Why the hell did you put pads on the patient? You can go, look, the patient started out in a left inferior fascicular hemiblock. They progressed to a bifascicular block. That indicated that their conductive system was failing, and that was an indication to prepare for pacing, right? You actually have a solid rationale for doing that, when you wouldn't necessarily do it on other patients. So that's actually kind of a cool thing, and it's almost like an early warning system in a way, that as you see these fascicular hemiblocks become worse, that tells you, that gives you some time to kind of prepare. Okay, I'm going to pull the atropine out. I'm going to get the pacer pads on, and I'm just going to be ready in case this thing, the whole shebang ends up failing on me. So from a practical sense, that's why the fascicular blocks are helpful, because they can tell us, they can give us an idea of where this patient's progressing. What are they progressing toward? Oh, they're progressing toward a pacemaker potentially. So does that kind of make sense, the kind of the importance of them? Okay, excellent. Guess what? I think that's all I want to do for you guys today. We've gone over a bunch of stuff. I know it's a little early, but we have literally just gone over a massive number of topics.